Sorry. Sorry, sir.
Next, I would like to call Dr. Ritesh Agrawal, sir. He is a thyroid, endocrine and breast surgeon, currently practicing in Leelavati Hospital and Bombay Hospital, Mumbai.
Next, we would like to call upon Dr. Dr. Sanjay Gandhi, sir. He is a consultant histopathologist currently practicing at Shalby Hospital. He has more than 15 years of experience in the field of surgical pathology. Thank you. We welcome you.
Thank you so much. My expert panelists are with me, and this is an interactive session. So we can have any questions in between, even from the audience. We would be happy to take up. So without further delay, first I would like to invite my co-moderator, Dr. Amit, to take up first case. डुप्लीकेट यानी ये नहीं आ रहा है तो कैसे करना है
सेव नहीं हुआ लगता
नहीं सेव हुआ है ना तो गए यानी हाउ डू आई डू ये आ रहा है
ये ले लेते हैं चलेगा
वो तो गए सिर्फ डुप्लीकेट ही करना पड़ेगा
आई डोंट नो
ये बात
क्या करूँ ओपन ओके
So we are just discussing about the run-of-the-mill case. Actually, she's 31-year-old female from Jharkhand, and there is a swelling on right side of the neck since 4.5 years. There is some symptoms like occasional difficulty in swallowing. Apart from that, there is no change in the voice and other symptoms. So, just to Dr. Ritesh, if the patient comes, how will you further evaluate these cases? What sort of things that goes in your mind, and what kind of investigations that you will order?
Thank you, Chairperson. See, this is a very straightforward case, very common case in our clinical practice. Very common. Young or middle-aged lady and swelling for past many years comes in our OPD. Having some of the compressive symptoms, some may be present, may not. The first and foremost investigation is the blood testing. I presume it is a thyroid swelling. So first and foremost is the blood testing to rule out functionality, that is TSH or combined T3, T4 and TSH, number one. And second is the imaging in the form of high resolution sonography.
Okay. So ultrasound has been done for this patient. To my co-panelist, how will you do evaluate the thyroid nodules, and what actually you look into the ultrasound findings?
So as sir already said, Kaustup sir, that no radiologist is a radiologist if they don't evaluate thyroid with thyroids. So that is, we'll see those thyroid nodules in form of how they are composed, like solid, cystic, mixed, how is the echogenicity, whether they have any calcification or echogenic foci, margins, and as usual, taller than wider or wider than taller. So these are the prime things. Dr. Ami has already discussed a lot in the morning. So these are the things. On those basis, we would stratify the lesions into thyroids.
Okay. So we do risk stratification and try to label that what is the risk of that particular nodule or multiple nodules if they are there, whether it's 2, 4, whether there is any nodes that is there. What's the need of doing tissue sampling? When you advise tissue sampling, that is the main thing that will comes in this thing.
So, if it is Starets 3 or 4 and the size, if it's more than 2.5 centimeter, then we can go ahead with the tissue biopsy. And then I think it depends on the age also, more than 35 years, it is even more than 1.5 centimeter size nodule. If it is Starets 4, it has to be biopsy.
Yeah. So depending upon the risk, so the size and the risk both, if we combine, then whether it is 1 centimeter or 2.5 centimeter, and then we will further evaluate. But the practice might change from person to person and the referral. This is outside biopsy. Yeah.
In the
please.
previous photograph,
Yeah. Please.
had you applied color on this?
It's hypervascular.
One funny thing is that in thyroids, vascularity is not a criteria.
Yeah, correct.
But in our practice, when we have seen the vascular lesions, they are more towards malignancy.
Yeah. So I do agree with you because thyroids is generalized. So every radiologist can practice if they don't have the color Doppler. Yeah, please.
Yeah. See, the size does matter, as he said, but my criteria would be 1 centimeter should be the cutoff. And even if the nodule is small and it is in the extremes of age, the younger childhood or elderly gentleman, you should also go in early and do at least sonography guided FNAC.
So as we said that these things vary from institute to institute, and when the thyroids came, it was the main focus was that every radiologist, those who are having a grayscale ultrasound, can adopt these and actually can classify these nodules into thyroids category. We have our own TMC risk certification in which we do take the elastography and color Doppler into account, but I'm not going into that. This is the outside report that has been labeled that there are multiple nodules, query benign, query multinodal goiter, and we will see that they are not labeling typically that what we have seen that they will label as in thyroids. So what you will do with these kind of reports?
I would request my radiologist to comment on each and every suspicious feature. I think there were microcalcifications present in that on both the sides in nodules. You told it is hypervascular. So vascularity, microcalc, hypoechogenicity, solid or solid cystic, irregular margins, taller than wide. These are important points which every radiologist should mention in the thyroid reporting.
Yeah, correct. So at least if you are not have labeled, but we will try to label into these things, but mention all the synoptic reporting system into the reports. So what to be done next if we have a report like this? What do you do with the patient?
It is not necessary to send the patient to repeat sonography, but discuss with your own radiologist with the report and the photographs. That is better idea. And then get a picture, because radiology reports will always differ. It is observer variation.
So yes, very true, and that is the reason that because there is a lot of variability who does the ultrasound. It has been discussed and then asked for probably looks to be high risk, and this was the FNAC report that has been there. So do you agree? And just to the pathologist, how they require a clinical input, they require a radiological input to make their Bethesda scoring system to come into live to the patient?
So it again goes back to USG findings. If they tell us it's a high risk nodule, go ahead and do FNA. If they say it's a low risk, because this is a gray zone, and unless you do molecular biomarkers, you cannot decide whether to go ahead with surgery or not.
Yeah. So that we have discussed, and this is how whether there is any role for repeat biopsy. You have talked about molecular testing, or maybe you will further go ahead and do some kind of surgery in these patients.
No, if the size is less than 1 centimeter and no ultrasound suspicious findings, then I would observe repeat sonography after 6 months and see if what is the doubling time, what is the volume, size volume. Then depending on that, we decide on the FNAC.
So correct. So these are very essential features. If we mention, then we have to mention each and everything apart along with the size. So actually their growth can be monitored. And this is the repeat ultrasound that has been done. The repeat FNAC is category 5 or maybe the higher. Whether there is any role for now upfront surgery, or you require the role of any plain CT, contrast CT or MR in these things. So this is the ultrasound images that were there in these type of nodules.
If I have a suspicion on ultrasound, a strong suspicion, I will definitely go for a CT scan, contrast CT. There are some things which we can interpret ourselves on looking at the photographs, and we can discuss with our radiologist directly. So, if strong suspicion, there's no harm in doing a CT contrast CT. So that should include the upper mediastinum also.
Yeah. In your practice, in which lesions you will prefer for doing a CT scan? Like this is a specific scenario, but otherwise, what are the conditions where you will think that the CT has been need to be done?
Can I take that?
Yeah, please.
It's a centrally based nodule, posteriorly based nodules, TO groove. These are the sites when you need to, and if sonography says that the nodes lateral in the neck, these are the.
Yeah.
In my practice, see, I am in a corporate setup. I cannot miss even a single thing in surgery. So in my practice, it is a routine for the past 10 years or more. I have been doing contrast CT in all patients before surgery. It is as a rule because in my initial years, we had missed detached thyroid nodules or thyrothymic rests which were present behind trachea and that were not seen on sonography. So we had made a rule, it is our protocol to do a contrast CT before surgery in every patient. There's no harm in doing a single CT scan.
So again, the protocols might vary from institute to institute, and we can actually discuss about the guidelines.
I too had a question because when we do contrast CT, then that interferes with the next imaging, if at all iodine.
Like iodine.
Yeah.
See, don't worry about this thing. Nuclear fission is there. Yeah, sorry. So what happens? Be practical. We do not know when the nuclear physician will get the next iodine. That is their thing. So we should not interfere in that. CT scan, when we do the CT scan after 4 weeks, we have to wait for the iodine. And in waiting for 4 weeks, there's no harm, even if it is a high grade malignancy, there's no harm. Better to wait for 4 weeks and then do iodine imaging.
Because that's a common question.
Because there's no urgency to give iodine after surgery in any case of CF.
Sometimes vascular invasion is more required for CT scan. So for that, for contrast CT scan is necessary. And for radioiodine, any scan or therapy, we just need the 4 weeks. Or sometimes we use a dilution technique also. We give the diuretic to the patients if we want early. But in the 4 week, all contrast is washed out, or we can go for the
Yeah,
diagnostic.
so we are actually now in the era where there is a water soluble contrast and they will wash out from 4 to 6 weeks. And
Now with the availability of thyrogen injections, you can do it on day 5th post surgery.
Yeah.
So what you need is just an high increase in TSH.
so
There's a difference, sir. Even if we give thyrogen, we have to wait for 4 weeks because we have given the contrast. So even if we for contrast, if we have given contrast, then we have to wait for 4 weeks, either with thyrogen, without thyrogen.
So actually in our textbook it is 6 to 8 weeks. That is
4 to 6 is max, sufficient.
So I think there is a range we can actually call about. Maybe it is from 4 to 8 weeks. If we decide from the panelists, that is okay. It doesn't matter. The main thing is that we need to have a proper workup in the form of ultrasound. We need to have a proper workup. There are specific set of indications for doing a CT scan.
I don't think in guidelines it's not mentioned you need to wait for 4 weeks. With the very fact that thyrogen is available, it's only for that reason. We have got it done on day 5th.
So now
They just need, I think,
new set of guidelines are available. 2025 guidelines are available from the ATA. We will discuss that later. From the radiologist, do you think what are the areas that are actually involved and how will you report the extent on the CT scan and what are the areas you want to stress upon?
So if the tumor is big enough and it is in the centrally located, then we have to see the trachea and esophagus. What are the tumor circumference to the trachea and esophagus? If it is more than 180 or so, or there is a mucosal irregularity, or you can see a frank tissue projecting within the lumen, then it would suggest that there is an infiltration. You have to mention the extracapsular extension at the posterior aspect also. Try to always find out that fat in the tracheoesophageal groove. If the fat is effaced, then recurrent laryngeal nerve might be involved, or if the patient has hoarseness or vocal cord palsies. And of course, if it is laterally based, then carotids and IJV, these needs to be looked as well. And nodes in the mediastinum, in the lateral compartment, the central compartment.
So to the surgeons, now we know that there are multiple nodules in this and they are high risk. There is a well differentiated thyroid carcinoma. Particularly the next line of management, it will be how will you proceed with?
I would like to risk stratify these patients. There are special criteria. M is classification. A stands for age, M for metastasis, E for extrathyroidal extension, and size. So age less than 50 years, no extrathyroidal spread, no metastasis, and the size is more than 4 centimeter. Conservative surgery, that means the lobectomy is good enough, provided there are no nodes, opposite lobe is normal. And all these things can be assessed clinically. So in majority of thyroid malignancies, sonography is the sole and only investigation, barring couple of cases.
Yeah. So in this, it was because bilaterality is there and then there are multiple nodes as well, and then it was decided to go for the total thyroidectomy.
I would request my radiologist to comment specifically on lymph nodes in this patient,
Yeah.
both on sonography as well as CT scan.
Yeah. True. What is the role of radioiodine therapy post?
In the 2025 new guideline according to ATA, now we follow the data system. Data is the D for diagnosis, A for assessment for risk versus benefit, T for treatment, and R for response evaluation. So we follow the risk versus benefit assessment. So we after the surgery, we categorize the patient in the low risk criteria, in the low to intermediate risk, intermediate to high risk, or high risk patients. The tumor is less than 4 centimeter. There is a unifocal, no any vascular invasion, capsular invasion present, is come as a low risk criteria. So we can follow that patient on follow up. Not radioiodine therapy is indicated in that cases. In case of low to intermediate risk or intermediate high risk patients, when the tumor size is more than 4 centimeter, when extrathyroidal extension is present, capsular vascular invasion is present, nodes are positive, then we can advise for the patient for the radioiodine therapy. And one thing Jay sir mentioned, after surgery, when contrast, no any history of any contrast interference, after within 2 weeks with the help of recombinant TSH, we can give the diagnostic and therapeutic scan for the patient. We don't have to wait for 4 weeks after the surgery. Thank you.
So thank you. By looking at this, we have discussed about how it's most commonly present as a clinical scenario. What is the role of ultrasound? How will we do the risk stratification? What is the role of CT to know the extent of the disease, and what are the various management options, and the role of involvement of the nuclear medicine people in that. So with this, I would like to end, and I would invite my co-moderator, Dr. Diva, for the next cases. Thank you.
So after the thyroid nodules, we'll discuss some of the mimics, because in our routine radiological practice and in our clinical practice, we see many a times the symptoms are overlapping, and it is really difficult to differentiate which is actually a true Bachchan. So let's begin the case first. So a female of a 56-year presented with hoarseness of voice. There was a history of dysphagia and lower neck swelling. On examination, there was a firm hard swelling in the lower neck in midline, which was not moving with the deglutition. Hopkins was done, and it revealed there was a left vocal cord which was fixed. Rest of the larynx was normal. Endoscopy was done since there was a history of dysphagia. So it showed a luminal narrowing with a ulceroproliferative lesion, which is noted just below the cricopharynx in the upper esophagus. Adult scope could not pass, and biopsy was taken using the pediatric scope. So clinically, it appears to be an esophageal lesion, looking to the clinical history. So since scopy was done, biopsy was taken. On biopsy, there were fragments of squamous mucosa with papillary pattern and acicular nucleus with intranuclear groove. This was the biopsy report. Now my question to the clinician, what next investigation would you like to do in this scenario, to Jay sir and to Dr. Ritesh?
Okay, so we have this biopsy report. Now the confusion is there, it has a papillary pattern. Papillary pattern may arise from anywhere else also. It's very common. It may be arise from GI tract as well as other lesions like thyroid or kidney. In neck, if it is there, I would like to give the benefit to the thyroid. Hence, I would like to investigate like in the form of CT scan, ma'am has already mentioned, and immunohistochemistry. Both are mandatory. IHC for thyroglobulin, TTF1, and squamous cell lesions. So this will clarify where the lesion is coming from. It is from thyroid origin or from some other origin.
Correct.
That is mandatory.
Absolutely right. So since the biopsy is showing papillary pattern, and as sir rightly said, that we need to know the origin of the organ. So we have done the same thing in this scenario. So we have done the CT scan in this patient. And here are the CT images, cranial to caudal. You can see the axial images. So I'd like Dr. Shikha to describe this lesion. That what do you think about it?
So there's a poorly enhancing lesion almost replacing the entire left lobe of thyroid gland, and the epicenter seems to be more of thyroid and then extending posteriorly in the tracheoesophageal groove, and possibly involving the esophagus. That was there in the endoscopy as well. And
So that you are absolutely correct. So basically there is a large bulky lesion which is involving the left lobe of thyroid. It is also involving the esophagus. It is also extending in the TO groove, which is well explained that patient has a laryngeal palsy as well. So my question is, how can we differentiate this thyroid infiltrating esophagus versus esophagus infiltrating thyroid gland? Any radiological clues that can we differentiate, and what are the, if yes, then what are the features?
I think we should look at the epicenter of the lesion. If the epicenter is more towards the thyroid, then it would be thyroid infiltrating the esophagus. Calcification would probably give us a clue that this would be a thyroid malignancy.
Correct. So I think in this case, we do not see any calcification so far, but there is a large soft tissue which is involving the epicenter is more of not mucosal, it is more of a submucosal and extra serosal from the cricopharynx. So it looks like, yes, it is thyroid infiltrating, maybe more likely, looking to the biopsy scenario also. So what will you suggest to your clinician? How should we go ahead further? What next investigation we should do it?
Now,
Any radiological?
it's a big lesion on CT as well, with an extracapsular extension invading the adjacent structures. We need to investigate whether there is any metastatic disease present or not. In CT, I couldn't find any notes in whatever the images has been given.
Correct.
But still, we need to evaluate the patient further before going ahead for a radical surgery.
Right. So any further, so basically the biopsy was done during scopy. So it was so what can be done the next, any investigation? So I think since there is a large soft tissue, which we can see on ultrasound, which is mimicking as a primary thyroid. So in this case, the ultrasound was done since the scopy and CT was done. So after that, the ultrasound was done, and here on the ultrasound images, Shikha, if you can enlighten more about that, there is a lesion and there are the nodes. Now here you can see well.
Yeah, so this is a very hypoechoic lesion with a frank extracapsular extension. The nodes are pathological as well.
Correct. So here the lesion is not showing any calcification, but in the nodes you can see typical microcalcifications.
So
Here
it could
they
be
are
a papillary also.
Correct. So in the after this ultrasound, the ultrasound guided biopsy was done in this patient to see that we can have more information, we can get more tissue. So the ultrasound guided biopsy from the lesion, again it shows papillary thyroid carcinoma which was favored. So I would like to ask Dr. Sanjay that what is the role of IHC in this kind of dual picture where the patient presents with typically ulcerated growth?
Yeah, particularly in this case, the question was whether esophagus tumor going into the thyroid or thyroid is going to the esophagus.
Yes.
Immunohistochemistry will help because thyroid has specific marker, Paxate, thyroglobulin and TTF1, and in this case they were positive in both. The IC was done in both the case, so both the tumor have similar findings. So it was positive for TTF1, thyroglobulin and Paxate. So it was consistent with primary papillary carcinoma of thyroid extending and invading the esophagus.
Very true. So now we are.
One question to the pathologist. Will you prefer to do calciponin staining in this patient?
See, thyroid malignancy more rely on nuclear features. In this case, there were classical features of papillary carcinoma of thyroid. So here the rule was to differentiate whether the esophagus papillary carcinoma extending to there or papillary carcinoma going into the esophagus. So in this case, there is no medullary morphology. Medullary carcinoma is a neuroendocrine tumor. They have typical morphology. So I will not go and don't waste the time and calcitonin in this case. Yeah.
Any differential in the form of anaplastic cancer, because she is 51, hard fixed mass. So anaplastic cancer is also a possibility.
Again, I see anaplastic carcinoma, again the morphological findings. We can see no typical thyroid features. What we see in anaplastic carcinoma, spindle cell variant, squamous variant, pleomorphic variant, we have to hunt for thyroid. Anaplastic carcinoma means they have anaplastic, they lost the thyroid marker, but still, sometimes they lost thyroglobulin TTF1, but still the marker they retain is Paxate, but not in all the case. CK will be positive and that will tell you only the carcinoma, that will not tell you the site of origin. And even sarcoma can be CK positive, epithelioid sarcoma can be CK positive. Immunohistochemistry is just an ancillary study. You have to use your brain and morphology. That will not tell you the diagnosis. Yes, sir.
Tell us whether it is diffuse sclerosing variety.
It is the, sir, actually it is a tall cell variant we can say, but it is a small middle core biopsy.
It goes more towards poorly differentiated.
No, sclerosing variant is the type of thyroid carcinoma that is aggressive, but in true cut biopsy we can see sclerosis, whether it's the tumor desmoplasia or true sclerotic variant of, so we will not try to subtype the papillary carcinoma in true cut biopsy.
Okay.
But it is important for the surgeons, because
Yeah.
if it is anaplastic, I will not operate.
Of course.
That is,
This is not anaplastic carcinoma. This is
but,
not anaplastic
but even if it is
carcinoma,
poorly
there is no
differentiated.
anaplastic features of thyroid in this
The
case.
question is, can we differentiate papillary subtypes?
On true cut biopsy it's difficult.
It's difficult.
Yeah.
In this patient, I would like to do further few more testings, which will give us clue. One is serum thyroglobulin,
Okay.
because this is a difficult scenario. If serum thyroglobulin is high, it's a clear-cut diagnosis of thyroid CA.
Yes.
Though it is not reliable marker usually, but in this patient, definitely serum thyroglobulin will help. As I told, it is a small biopsy. In that biopsy, medullary features are not there. But in these kind of patients, hard fixed mass, to rule out MTC is essential. So serum calcitonin is also helpful.
Correct.
LDH should also be done.
So, my question to Dr. Jayesh sir, that what information additionally you want if you want to go ahead further with the surgical planning from a radiologist?
To me, this is an inoperable cancer of the thyroid.
Correct.
But still, if I have to ask, I'll ask the visceral involvement. If the trachea is involved, I need to know the number of rings involved. Esophagus, what length of esophagus is involved. These are the things.
So, Dr. Shikha, can you more elaborate what are the local invasion signs and what are the features that you should look for? I think you have already narrated in your previous discussion with Dr. Amit Janu. So, if you can go ahead again once.
Yeah, so extrathyroidal, extracapsular extension at anteriorly to the strap muscles if it is there, laterally to the IJV carotid vessels. So you need to always mention how much is the circumference or the vascular encasement is there, whether there is any luminal narrowing, direct involvement, tumor thrombus is there or not. Posteriorly, you need to see the fat planes with tracheoesophageal groove as well. And then of course in the centrally or medial compartment trachea in the esophagus, as sir said, try to identify tracheal ring. Long back, Kaustup sir used to send us patients for MRI to identify the tracheal cartilages, I remember, and we had a hard time looking at that, but that is what they want. How much is the length involved if it is esophagus, and you need to identify whether there is any subtle sign of mucosal irregularity or a frank tumor tissue which is protruding into these structures.
So this is one of the Sheen classification, and this is one of the very good article which is recently published in 2024 where they have talked about the locally advanced thyroid cancer and modified Sheen classification and the grading system of the tracheal invasion. So apart from this tracheal invasion, what exactly other features, if this is, for example, if this is an operable case, then what other information you would like? Do you need really the length of the trachea? How much?
Yes.
So that is important. Anything from the level of the carina, you need that distance?
No, generally in thyroid cancer invading the trachea, you can easily get away by excising 4 to 6 rings.
4 to 6 inches. Correct.
So if it's beyond that, it becomes difficult to do an anastomosis, even if you
True.
release the carina.
Okay.
And this is a patient where I would like to get a FDG PET also.
Coming to the next slide. So basically in this case, it is a Sheen grade 2 tracheal encirclement and grade 2 invasion. So here you can see clearly. So now my question to nuclear medicine, of course, has already been discussed. So do you advise FDG PET in such scenario? Of course.
Yeah, in this case, FDC PET-CT definitely will help. Two things, that to rule out any distant metastasis, and other thing, the prognostication. If FDC PET is positive in the thyroid lesion itself, it's a much more positive, chances of poor prognosis more high. So there are two things we can detect on the PET-CT. The PET-CT was done, which is clearly enhancing lesion in the left retrothyroid region, infiltrating the left lobe thyroid, with nodes are positive, and both bilateral cervical nodes are positive. And then there's a right axillary node is also positive, is looking the similar uptake like the well-rounded node, and similar uptake like the thyroid lesion. So it is definitely looking metastatic. However, we advise for the histopathological correlation from the right axillary lymph node to confirm the metastasis. But this is the case of locally advanced CA with axillary node mets.
In this photograph, the lower one, do you think the spine right side, the transverse process has some metastasis or it's an artifact?
No,
Yeah, this is the artifact.
yes.
In general, if pathologist tells you papillary CA, differentiated thyroid cancer, I don't think there's any role of FDG PET. It's only in poorly differentiated, anaplastic, and recurrent scenario and medullary CA.
But sir, in
these
this,
are the only, in general, I wouldn't,
So the
in this case, we have received only true cut biopsy, and what's the anaplastic it's possible we have not received the anaplastic area because this is a locally advanced tumor. So I think PET scan may be helpful in this.
So here the most important role of radiologist. Do a proper USG guided biopsy, hit the proper area.
Correct. So in such scenario, since now it is like this is a M1 disease, what is the role of neoadjuvant
why did you label it M1?
Axilla.
Oh,
axilla? See in a previous images, yeah. So it's a locally advanced with a M1 disease. So would you sir enlighten for what are the treatment options for such scenario, if not surgical nowadays?
This is unresectable thyroid cancer, so upfront surgery is straight away ruled
No,
out.
correct.
Most probably it's a differentiated thyroid cancer, and even if it is going towards puberty or anaplastic type, there is definite role of tyrosine kinase inhibitors, and the commonly available which we use is lenvatinib. It has given a very good result.
True.
But the minimum time is, I think, 2 to 3 months.
Okay.
There are a couple of more drugs available, but they are not in India.
So
The role of neoadjuvant chemotherapy in that
Yeah.
case,
No. TKI is better. Lenvatinib 4 mg you keep on giving for 2-3 months, 4 months. There's no harm because patient is not going to die soon. We have done the FDG PET. No significant metastasis. Only local regional disease. Lenvatinib will cause a significant reduction and then we can operate.
Second thing is, in this patient, even if it becomes operable, less than 10% chance of she or he surviving more than 2 years.
So the crux to the radiologist that even though the thyroid and the upper aerodigestive, it is in very close proximity to each other, the incidence says that there are chances of infiltration of thyroid infiltrating the cricopharynx and the esophagus. It is less than 15%. We don't see the mucosal involvement of the esophagus so commonly in a locally advanced thyroid disease as well. So that's the crux for a radiologist here. So moving to the next case, a 41-year female, palpable firm swelling in right lower neck. There are histories of bone pain. Hopkins, both the vocal cords and larynx was normal. Thyroid function test was normal. Serum calcium was 13.8. Clinically, yes, there is a thyroid nodule with query hyperparathyroidism looking to, there is a history of a bone pain. Serum PTH was done and it was quite high, 1025. So since there is a neck swelling, the ultrasound was done. So here you can see a right thyroid cystic lesion. It was graded as thyroid's category 3 since it is primarily a cystic. Ultrasound guided FNSE was done in this patient and it revealed Bethesda category 2. No parathyroid adenoma was identified in this patient. So my question to both oncosurgeon and endocrinologist, what are the other imaging options available in this scenario?
Can you go back to the first? Yeah. Let me tell you the clinical diagnosis. Clinically, it is a parathyroid carcinoma. See, a patient with a hypercalcemia, calcium is more than 13, pH is very high, a palpable gland. Don't think of other diagnosis unless proven otherwise. We had done an extensive study and we had recently presented poster outside also. 11 patients of parathyroid carcinoma, all were palpable glands. So a palpable gland in the setting of hypercalcemia, don't think otherwise unless proven otherwise. And if the clinical diagnosis is parathyroid carcinoma, please do not go for a biopsy or FNSE. It causes needle tract seedling. It's very important. So make a clinical diagnosis, do imaging studies as per the hyperparathyroidism and then operate.
Correct.
What sort of surgery do you do in this patient?
On block session.
We'll come with the.
Okay.
So, what are the imaging options available in this scenario? So, my question to Dr. Krishnakant and Dr. Shikha both, that what are the anatomical and functional imaging which we can do further in this scenario?
Regarding the anatomical imaging, ultrasound and CT scan, and for the functional imaging, we go for the parathyroid scintigraphy. There's a system, maybe scintigraphy or tetraphosphine scintigraphy, with the help of SPECT-CT. SPECT-CT which help the exact location of the parathyroid lesion, and other PET tracer like PET choline and PET rivaxin. PET choline is the 18F best PET tracer. It is very very fewly available in the centers. So we go for the gallium rivaxin tracer for this for the functional imaging.
So, can you more enlighten about the availability versus cost and the specificity particularly?
The both PET regarding the SPECT and PET tracer. A SPECT tracer have limitation because it doesn't have any less spatial resolution as compared to PET tracer. In the PET tracer, we have two tracer, choline or rivaxin. Choline is the 18F best PET tracer, so we have depended on the cyclotron, where the cyclotron is available, they provide us 18F choline. Better thing about the gallium rivaxin, because the gallium based generator, we can produce in any center we have gallium generator, they can produce and label with the rivaxin. So it is more easily available than the PET tracer. However, the cost is higher than the normal PET. Gallium rivaxin costs around 30,000-35,000, but spatial resolution is improved by the gallium PET tracer. So in that case, we have suspected multiple adenomas. So we better to opt the PET tracer regarding less than the SPECT tracer.
Correct. So, in this case, as we concluded, of course, the first line is ultrasound to locate the parathyroid adenoma or hyperplasia, and the commonly available system may be SPECT-CT. If there is a negative or discordant, there are other modalities. So, what to be done, that Dr. Krishnakant has highlighted. Dr. Shikha, you can highlight on the anatomical imaging.
So sir is suspecting parathyroid carcinoma. We have only one lesion in the thyroid from which it was a colloid as in the biopsy. So we need to go ahead with the cross-sectional imaging also, that is 4D CT. Not only to look at the thyroid and the parathyroid, but also the ectopic sites, if at all anything is there, and to identify the surgical landmarks, to see any variant vascular anatomy is there, anatomy is there, and of course to look at the nodes in the mediastinum and as well as in the neck.
So this is the system AB scan finding in this patient, which was done, technetium 99. So it is a confusing report that parathyroid adenoma with a normal tracer uptake in thyroid gland. So this is the report. So the clinical scenario, as there is of course a hyperparathyroidism with no parathyroid identified on ultrasound neck region, and with the system AB scans showing that there is adenoma with normal tracer uptake in a thyroid gland. So again, a question to my panelist, that negative, equivocal or inconclusive causes, what are the causes, what it can be? Apart from ectopic, are there any technical issues which happens during scan which lead to this kind
Yeah,
of?
in the normal parathyroid scintigraphy, the first limit is the small lesion. When lesion is very small, we can miss out on the normal parathyroid scintigraphy. And sometimes the large adenoma is also wash out is early than the thyroid. So that in rare cases we can miss out in the large adenoma also. But most important, the small lesion definitely we can miss out on the normal parathyroid scintigraphy. And when the suspicion is more high, for even normal negative parathyroid scintigraphy, always advise either go for the 4D CT or other PET tracer.
So in that scenario, the choline is the better.
Yeah, definitely. If the choline is available, choline is the better than the normal parathyroid scintigraphy, and other tracer like we use 4D CT or PET vaccine. The major is if the clinician suspicion is higher, then don't directly jump to the PET tracer. We first go for the 4D CT. Most of the time, 4D CT will help. When 4D CT is also normal and we suspect him ectopic parathyroid adenoma, then go for the PET animal molecules.
Correct. So
I have a question to the nuclear physician. At what places in India this PET choline is available?
PET choline available in the many center. It is when cyclotron is working, they all provide choline.
In India, which cities?
Yeah. They can in the bomb they can send us to the choline also. However, it is costly because for one to a patient the PET tracer the airport cost is high. But choline is available in many centers and they provide us. They have cyclotron. They provide us the choline.
What is the differential between gallium DOTA-NOC and have you any experience with gallium RGD?
Gallium DOTA-NOC in that case for parathyroid, the parathyroid all indication for the when we suspecting some man syndrome like syndromic cause. To go for the DOTA-NOC and RGD tracer actually is very less available. First is the thing, and I don't think so. RGD is mainly the angiogenesis based tumor. Which tumor is more angiogenesis go showing uptake on the RGD PET. So any tumor we have vascularization, it can show pickup on the RGD. So generally, because of the less availability of the RGD, we don't go for RGD. However, 5P PET CT is now involved in, so we can do for 5P PET CT for this patient, but we choose for the gallium trivexin more than the 5P in that case.
So, sir, I would like to ask the question. Can we differentiate the clinical signs of parathyroid adenoma versus carcinoma, the other clinical signs apart from the biochemical markers?
In my book, parathyroid carcinoma is always an accidental diagnosis.
Okay.
By and large, if it is operable, and the easiest way to prove this is instead of wasting so much money on a lot of scans,
Okay.
take out that nodule, wait for half an hour, get your
PTH done.
If it falls
Correct.
by more than 50%, you know you hit the right
Correct.
target.
All right. So here we have, since the scintigraphy report was inconclusive, confusing, and we want to locate the adenoma. So 4D CT scan was done. So Shikha, you can highlight more about the type of parathyroid adenoma, how we can see if you can highlight more on the cause, how parathyroid adenoma, which you can differentiate, what are the normal contrast imaging pattern on 4D CT scan. So if you can highlight more
So
about.
we have already seen in detail in Rushi's lecture that 4D CT is as routine as CT, just we take a fourth dimension into the time. So we see the arterial enhancement, whether it is more hypervascular than to the routine thyroid tissue. You start with the plain scan, how is the thyroid density and the nodule density, whether it is same or not. Then you go on to your arterial scans, whether it is more hypervascular or not, and then find out whether it is showing washout or not. We've already seen that those which is common pattern is less in the adenomas, like more hypervascular and showing washout, but it is only seen in 20% of the patients. You can have type B curve also, and then you can have those which are non-hypervascular also. So there are different patterns on 4D CT also, where you can try to identify the parathyroid, and as it is already said that you have to correlate your findings with systemically if it has been already done. You already have a faint idea of localization where you want to look at.
So in this case, these are the 4D images of the same patient, the large nodule within the thyroid gland, and you can really see the hyper enhancement of the peripheral.
One of the component.
Yes, one of the nodular solid component here in the early part here you can see, which is, and even on the delayed scan here, which is showing the washout. So basically, we know that non-contrast hypoattenuation, early arterial hyperenhancement and washout on delayed phase that favors parathyroid adenoma. We know the migration of parathyroid gland into thyroid gland is extremely uncommon and one of the potential cause of failed diagnosis radiologically, and so the exploration also. So I want to ask to Dr. Sanjay as well and to the clinicians also, are there any range of serum calcium and serum parathyroid to differentiate? I mean, are there any gray areas?
Yeah. See, if calcium is not very high, near 11, chances of multi-gland disease may be there. Along with the not very high, PTH is high, 200, 300, 400, 500. We have commonly seen even with more than 1000 PTH, 2000 PTH, and it is adenoma commonly. So the differential is based on clinical parameters rather than biochemical parameter. Biochemically, calcium and PTH both can be high, but in carcinoma they are very high. Along with the end organ damage like pancreatitis. Pancreatitis is a common feature in pathoid carcinoma. It is not so commonly seen in pathoid adenomas. Also, if it is a palpable gland is a hard gland. Usually pathoid adenomas are very soft, just like a cotton, रुई की तरह होते हैं. So even on surgery, if you feel them, they are very soft. Usually they are not palpable. If it is a palpable gland, always think in terms of carcinoma. This is a dictum.
Any comments, sir?
No, I wouldn't agree entirely because we often see parathyroid adenomas as big as 4 centimeters.
Okay.
Most of them come from orthopedicians and nephrologists. They are the one who pick up because the patient keeps going to them and occasionally psychiatrist. And if they advise sonography, something is picked up and then the entire chain starts.
So the clinical presentation will be different.
It's difficult to really differentiate between parathyroid adenoma and carcinoma unless it's pathologically proven. The treatment remains same. It doesn't change.
So I think in this case we have concluded, yes, there is intrathyroidal parathyroid, and looking to the PTH level, yes, it is very high. Likely it can be carcinoma. So in such scenario, are there any, I mean, how will you proceed further for the surgically?
Surgery is different in adenoma and a carcinoma. If I am thinking in terms of carcinoma, I will do a en bloc resection. En bloc means ipsilateral, that is on the side of lesion, remove everything, thyroid lobe, central compartment lymph nodes, and that very parathyroid lesion. And also check for other side parathyroid glands, do a bilateral neck exploration to see whether they are normal or not.
Contralateral also, will you prefer?
Contralateral bilateral neck exploration is mandatory in case if I am doing thinking in terms of pathoid carcinoma.
Even if it is
Yeah, even then. No, for pathoid carcinoma, it is intra-PTH is mandatory. It's mandatory.
For me, even if it is carcinoma, N0 neck, at best you can knock off that thyroid on the
Yes,
side of ipsilateral side.
correct.
That suffices.
Yes,
If there
so
are multiple nodes, that can be easily picked up on sonography or CT or 4D CT, whatever you have. So then you can decide plan your surgery. But N0 neck, I don't think prophylactic neck dissection helps in prolonging the survival.
It is already
is there
described
any
in
role of
all the
frozen?
pathoid carcinoma series that ipsilateral central compartment has to be done.
So is there any role of doing frozen for the nodal in case of parathyroid?
Definitely, as what you have suggested, if parathyroid has been dropped and we have also received the parathyroid and we confirm this is a parathyroid. In frozen, we say only whether it is a parathyroid or not. I will not try to comment on adenoma or carcinoma until unless grossly it is invading the adjacent structure. Okay.
But during frozen, you will be able to see the broad bands and septum.
Yeah, we can see the capsule and septa, we can see in frozen section. But in frozen section, in 10 minutes, we can see only 1 or 2 sections. So we can miss vascular emboli, lympholytic emboli, passing through the capsule and going into the other organs. So these are the features of malignancy. Even partial capsular invasion will not tell this is a carcinoma.
So you can, if you can read this for us, this is
the cysts of neoplasm. We can see they are mainly arranged in microfollicles. That star area, we can see the normal thyroid gland, and tumors are infiltrating that thyroid gland. So this is more likely, still this is a more likely parathyroid carcinoma than adenoma because infiltrating the thyroid gland.
correct.
What are the confirmatory features of carcinoma on histopathology?
Histopathological features, only one feature which I am going to mention. First, lymphatic emboli. Second, vascular emboli. Third, perineural invasion. And fourth, infiltration into the adjacent organ. And fifth, malignancy. If we find distant place, parathyroid metastasis, these 5 features, one of these 5 will confirm parathyroid carcinoma.
Right, absolutely correct, lovely. Yes, yes.
So we have evaluated around 130 patients with parathyroid adenoma versus carcinoma. And like Sir has already mentioned, it is about when there is an infiltration, there is a necrosis, and there is a dirty fat planes. Somehow we have also observed the calcification that is more common in the carcinoma rather than found in the adenoma. And if all those features and the size, apart from that very high biomarker levels, they are in thousands. The calcium was around in 17, 18 in the range. And if all those features are present, at least we will suspect that yes, there might be this thing, and probably these patients might require RT and other secondary things when there is a parathyroid carcinoma. So necrosis, infiltration, calcification, dirty fat planes, everything actually constitutes towards parathyroid carcinoma with very high levels, the calcium as well as the PTH.
And some even 5 to 7% are non-functional. I have seen a case of parathyroid carcinoma with normal PTH and calcium, because tumor is tumor, malignancy is malignancy. Yeah, it's yeah.
One more question from my side. Is there any role of intraoperative ultrasound? I'm not talking about this particular case, but I think Dr. Ami has experience of.
If you are doing a focused pyathyroidectomy, it is mandatory.
No, I'm talking about the. Yes, I mean, if the surgeon cannot locate, I mean, there is a parathyroid adenoma which was reported, but now PTH is not coming down. So how do you, I mean, further do during surgery?
Look for all the available ectopic sites,
Correct.
open them, and
Yeah.
and definitely you will find some irregular lesion or abnormal lesion there. You will find it.
If you cannot find and you don't have an access to sonography,
Yes.
just follow the branches of inferior thyroid artery. It's going to take you to the parathyroid. And you can knock off all the 6 parathyroid, 4 or 6, whatever number is.
True.
And maybe if you're confident enough, you have a good pathologist who tells you that this gland, remove this parathyroid, you can implant one of the glands or maybe one further.
So with this, I would like to end my session, and I would like to thank my expert panelists and for the excellent discussion. Thank you so much to all of you, and thank you all for this in this session. And I would like to thank all delegates. Special thanks to Dinesh Pateshal and Trupti Madam for having with us for the entire session. And once again, thank you to Kaustubh Patel sir.